Morning once again. So before I proceed further with my presentation on what we have done in India, I would really like to thank Professor Luza Gilbert from Columbia University, as well as Chairperson of GLORI Foundation, for giving us this opportunity to come to this part of the world, to Central Asia, and share what we have done so far, contributing to the women's right and empowering them. So before I go in depth, I just want you all to know how we have evolved, like how are we linked as per this slide that you see here. So I work in Alliance Regional Technical Support Hub. We provide technical assistance to NGOs, CBOs, even the international agencies who are working on HIV/AIDS, and basically our work is to help them in responding very effectively to HIV/AIDS and its related challenges, and not only in South Asia, but we are also focused in Asia Pacific as a whole. So we were established in 2009 as a technical support providing agency, and our mother organization, as you see, is India HIV/AIDS Alliance. India HIV/AIDS Alliance is a national NGO of India who is pioneering and one only NGO who purely works for HIV/AIDS response in India, in coordination with the National AIDS Control Organization under the Ministry of Health of India. And India HIV/AIDS Alliance is also the Global Fund's principal recipient for programs related to MSM and transgenders in India, one of the greatest grant ever provided by Global Fund to respond to the needs of MSM and transgenders. And also there is another Global Fund program for which Alliance India is a principal recipient that works for the treatment, care and support of people living with HIV and other key populations as well. So this is how we are linked, and our main agency is International HIV/AIDS Alliance, which is based in UK. It's a UK-based charity, and it works in different regions of the world. In this hall, if you see, I have my friend Chinara Bakirova from Anti-AIDS Association, who is also a linking organization or a partner organization of International Alliance. So that is how I am already connected to Ms. Chinara here, and I really want to thank that she could make it to come here today. And under the International HIV/AIDS Alliance project on community action and harm reduction that is funded by the Dutch government, Alliance India is doing a project, long-term project on harm reduction. So this is where from where the wings has come into the picture. When Alliance India was implementing the harm reduction program, we came across many women drug users, injecting as well as oral, who have been really facing a lot of violence in their lives, related to drug, related to their family, related to their sexual partners, their husband. So Alliance India, in partnership with International Alliance, was really looking for an approach in order to, respond to the gender-based violence needs of especially the injecting drug users, female injecting drug users. And we were recommended by OSF, the Open Society Foundation, to work with Ms. Luza Gilbert and GLORI Foundation on adapting the WINGS module in India. So that is how we have come into existence. And if you see this here in between, Sahara Al-Had, this is an NGO at the state level in Pune, in the state of Maharashtra, who works for the drug users, treatment, care and support, and it also has got its own care home for people living with HIV, and they are the ones who implemented the WINGS at the grassroots level for Alliance Regional Technical Support Hub. And as you see here, it's a bird, it's a flying bird, and in Indian language, wings means punk. So that is how we gave the name to the project as punk, just relating to the Indian local language, okay? So before I go, so I also want, I think most of you all already know that where India is and in which part of the world does India exist. However, I just want to let you all know that India is, of course, the 7th largest country in the world, and it is equally populated as its size is. And our neighboring countries, if you look at, is Nepal, Bhutan, Myanmar, China, Pakistan, Sri Lanka, and we share an open border with Nepal and Bhutan. So me, as a Tibetan born in India, my mother tongue is Nepali. So if you look at me, I have a cocktail kind of identity. Yeah, like I'm an Indian, but I speak Nepali, but originally I'm a Tibetan, a Mongolian by birth. So that is how the things have evolved. So just to give you all a brief background on the background on HIV/AIDS in India. India has the third largest HIV epidemic. So we stand third in the world when it comes to HIV epidemic. And the HIV prevalence among the adult population of India is 0.26. Just 0.26 prevalence rate. But here is a challenge, because we fall under, our number might be very small, 0.26, but we are very huge as a country. Population of over 1.2 billion population. So when we say 0.26% of people living HIV prevalence, then that already accounts to 2.1 million population of India is infected and affected by HIV/AIDS. So the response has to be very, very intensive and, reaching to the community. And then in India, if you look at the HIV epidemic, it is basically driven by heterosexual activity. That's how the data talks about, and which accounted up to 87% of new infections in 2015. So that is what the data says. And the HIV epidemic is still very concentrated among the key populations. And when we say key populations, as you all know, like we are talking about people injecting drugs, we are talking about sex workers, MSM, transgenders, we have truckers, we have other mobile populations under the key population who are very, very vulnerable and at high risk of HIV infection. And the most affected states in India. In India, we have 32 states, and some of the states are as large as Nepal, the whole country, I would say. Yes, and the most affected states of India are Manipur, Mizoram, Nagaland, Andhra Pradesh, Karnataka, which is in the northeast part of India. They are the ones which are very much affected by HIV, as well as now if you look at the epidemic, it is also moving towards north and southeast of India. So I would say that India as a whole is very much affected by the epidemic. As I said, that the prevalence rate of HIV among the adult population is just 0.26. But if we really segregate and look at the key populations, then PWIDs, people injecting drugs, has the highest prevalence rate by 9.9%. Yeah, and in the second we have MSM and transgenders by 4.3% of prevalence rate. Transgenders again, they have 8.82%. Yeah, and truckers and the mobile migrant populations are 2.59% of prevalence rate. So that is how the epidemic is in India. Now you can show. Yeah. So now I just give you a brief background, which was not there in the presentation. So now I will focus more towards the drug scenario and two wings. So in India, if you look at the drug scenario in India, the estimated number of injecting drug users is 177,000 drug users in India, out of which it is estimated that 33,000 of women are drug users in India. This is just an estimation, and if you there are many hidden groups of women and men who are drug users who have not yet been counted. However, the estimation just says that there is just 177,000 people who inject drugs in India or use drugs in India. And the highest drug prevalence rate, again, if you look at, is the northeast region of India, with states like Manipur, Nagaland, Mizoram, and Punjab mostly affected by drug use. And that's also because of the border that they share with Myanmar. And there's a golden triangle where the illicit drug trafficking is very high. And because of that, the heroin drugs, it comes in a purest form in Manipur, and it is very cheap. It's the price is very cheap. So anybody can access the purest form of heroin in Manipur. And that's also one reason why, this state is highly affected. Because of the political conflict in Manipur, internal conflict that they have, the youths have nothing to do other than, indulge in drug use and pass their time. So the drug use in Manipur is really fueled by the internal conflict that they have with the government of India. Okay? And, yes? Okay. National prevalence. Okay, 26. So if you look at, the response of towards drug users program through the targeted intervention of the government, 264 injecting drug users has been reached by the government's program. And this is the latest report of the government's body of 2016. Yes, so just to talk about the project Hridaya, there is a project in India HIV/AIDS Alliance that has been funded by the Dutch government, which complements the targeted intervention services of the government in helping them, reach to more of the injecting drug users and provide services like drug rehabilitation center, refer them for HIV testing and many more. So when Project Hridaya has been implemented in India, that is when WINGS has come into the picture. Okay? So now I go to the WINGS, the real place where I should be now. So the project, as you all know, that women initiating new goals for safety. The WINGS is a screening, brief intervention, and referral to treatment module for addressing intimate partner violence and gender-based violence among the women who use drugs. The model, as you all know, that it has been developed by the Columbia University, social intervention groups, and first implemented with women who use drugs in New York. Further, that has been adapted by GLORI Foundation and other NGOs here to be implemented in Kyrgyzstan. Yeah, and as I said, we have been supported by International HIV/AIDS Alliance Fund to implement the WINGS project as a pilot. And when I say pilot, it is not 3 years or 2 years, but we were just provided with a period of 6 months. And it has really been a hardcore pilot, I would say. Because, like in a very short period, we were really to understand if the WINGS module is feasible in India or not. Okay? And because like Technical Support Hub has to partner with a local agency at the state level, so we partnered with Sahara Al-Had. It's an NGO, as I said, it was easy for us to partner with this organization because they already had, drug users communities under their program, under the OST. So in order to reach to the women drug users, it was we went through Sahara. Okay. So just the structure of the project. The project site was Pune and Pimpri. These are two small towns in the state of Maharashtra of India. And the project period, as I said, was just for 6 months. We started in 1st of December, and it has recently ended on 31st of May. So we are yet to do the data analysis of the end line, and the data which I will be presenting is more of the baseline. Because, it has just ended, and by mid of June, we're going to come out with the data analysis, comparative data analysis of baseline and the end line. And the Sahara's project team that we formed in order to implement this project was, we had a project coordinator, 3 peer recruiters, 1 data manager under the overall supervision of the executive director of Sahara Al-Had. And as we all know that, it's very, very important to involve the key population themselves as staff members, in order to reach out to other peers. So the staff comprises, the staff, the structure that we have, the project coordinator, the 3 peer recruiters, they are, drug users, who were drug users in the past and still are on and off oral users. The project coordinator Nandini, she is a hardcore drug user so far as well, and the other 3 peer recruiters, they also come from the drug using background. So it was very easy for us to get linked to other drug users at the communities, the women drug users. And it is also there because they understand their issues, very well, and we are just there to facilitate the whole approach. And we believe that they are their best change agents that they can bring. So we had, we involved the women drug users as the project team members. And the target given to us was 50 women drug users, comprising, and which would comprise of injecting as well as oral. When we say oral, it was also, looking at alcohol users and oral drug users, and also some of the sexual partners of injecting male drug users were also involved. So objective, what exactly was the objective of PUNK in India was really to understand the scenario on GBV, IPV among the women who use drugs using the WINGS intervention. So, because till now there is no such research studies done related to gender-based violence among women. We don't have data. We don't know. We do know that what is happening with them, what kind of hardship that they face. But then we don't have any research or documents, data related to it. So basically, to understand exactly what kind of issues are faced, we thought like this would really be a very good model to build the capacity of NGO staff members in addressing the gender-based violence IPV among the women who use drugs through the WINGS module. So we also did a training in the initial phase of the project. We did a training of the trainers where we involved the entire staff members of Sahara and also the project team for WINGS. And in this training, it was a great opportunity, and for us to have Miss Luza Gilbert and Daniel in the training, and they really helped us out to implement the training very effectively, I would say. And the third objective is also to make women who use drugs realize the gender-based violence and intimate partner violence that they are facing in their lives and develop a safety plan for better living. That was the main objective, I would say. To develop a concrete, self-stabilizing and project retention plan to involve the PUNK participants as part of Sahara's current project period and as well as in the future projects. And the last objective, as we were looking at, was to include and implement the project's participants' feedback into the Sahara system to make its needs appropriate and person-centric. So the WINGS would also help us in, developing goals that would be, really as per the need-based at the individual level. What we do is we really plan for groups, and we don't narrow down to individuals. But through WINGS, we try to look at, addressing the needs of individual drug users, because the problem with me as a drug user would be different than my another peer, because we come from different backgrounds. Yeah, just a second, don't go to this slide. And before I go further, I also want to let you all know, when I said 50 drug users that we have, we intervened through this project, we know that they are drug users, women using drugs. But what kind of background do they come from? We don't know, right? Are they from middle class family, or are they very rich, spoiled children of, elite group of India? What background do they really come from, which has made them to indulge in drug use? All the 50 women that we reached are from street-based, under the poverty line. I really want to read out some of the identities that we came across. There was one woman who came from a broken family, deserted by parents, left to the mercy of the streets. She has nowhere to go. and she has to, she has to dwell on the streets. She has to sleep in the streets. She's a rag picker. She becomes a rag picker, and she sells those rags that she picks up for 100 rupees. That would be more or less 130 som in Kyrgyz currency. And with that daily wage, she has to, feed her stomach as well as, like take her daily dose of drugs that she's into. The other case was like there was one woman, a young woman who was married. It was a case of early marriage. In India, we really have a very serious case of early marriage. Because of the early marriage, women are deprived of so many, rights that they can enjoy as a citizen of India, as well as they also face, very, very, critical and very serious physical and mental violence. So, and there was also one case where the girl is so young and she's been raped by her husband. And when we say rape here, then it is, something that where there is no consent from the partner to have sex. So it was kind of rape for her, and she had been repeatedly raped, and when she never wanted to have sex. So all these things really, drove her towards the use of drugs. So these are the kind of women that we reached out, who were already into drug use. You go to the slide. So I just want to show you some steps of how we did the entire thing. Yeah, okay. No, just step by step I will. So like when we started the WINGS module, as I said, we first did is a training of the entire staff members. Then the first thing, once under the WINGS module, the steps that we have followed is enrollment of the women who use drugs. I think it's very much similar to what Project Hope has done. Then it was the consent form. We really wanted to take the consent of these women who use drugs, as we would be really discussing on very personal issues, very personal matters, and to have their consent to be with us throughout the project stages was very important. And this was also a part of the module itself. Then we did the baseline survey, where we had questions related to different forms of violence, different areas of violence: economy, financial, intimate partner violence, gender-based violence. So, so 350 questions, more than 350 there under the baseline, which every drug user went through. The woman went through this survey. Then we did session 1, followed by the session 2, where we did the safety planning, safety goal mapping, and finally we had the feedback session and the follow-up survey. So this is the steps that we followed as per the WINGS module. And the retention, now when we look at the follow-up survey, which is the end line, the retention has been 75%, more or less 75% of the whole target. And then the number of people outreach, women outreach, was 47, and all the data was stored in DATSTART, the software that I think even you people are using. So according to the baseline survey, the key findings that we have tried to collate, I would like to share with you all in some of the key parameters, like what intimate partners and non-partners with the enrolled women who use drugs in the past year. So if you look at, you can see the entire data. Some of the areas where they were the percentage was very high is called them insulting names such as fat, ugly, sluts, bored, which you can see that the intimate partners, the percentage is 85, which means many of them has been really orally abused by their partners, and even the family members, have really mistreated them. Okay, so he's telling me that I don't have much time, so I have to move faster. So if you look at people identified by the drug users as key perpetrators, who were them? So basically it is the husband, the boyfriends or sexual partners who have really been the perpetrators. And as a result of the mistreatment during one that the women drug users consider the most serious, or that has affected them the most. They are like the 75%, 77%, if you see, don't ask that their partner or client about whether they have STI, even if they suspect something, because they are afraid of further violence. So I think one of my colleagues from Home Project also really discussed that they cannot take the initiation to ask or really question about such infections to their partners, because that would really raise a violence. Because in settings like Kyrgyzstan, in settings like India, woman is always has a low social status, and that gender imbalance really influences the sexual activities as well, making the woman more vulnerable to HIV infection. And rate and variety of economic and financial abuse experienced by enrolled from their partners and non-partners since their relationship began. So you can see here 81% we have hide money so that the women participants could not find it. So financially they were really deprived. They were not, their partners, their husband never, shared with them the money that they were earning, depriving them of many things. And all this has again led them to use of drug in order to cope up with their emotional, status. People identified with the women who use drugs as key perpetrators of the reported economic and financial, again, husband, intimate partners, they are at the high rate. How often Project Punk women participants have a drink containing alcohol? 2 to 3 times a week. I think the highest is 4 or more times a week, because this is the last resort. Since they face violence in a daily basis, like they really have to, cope up with their emotional status. So there is no other thing rather than to drink alcohol and just be on the streets, just lie down and, not bothering about the environment that they are in. So Project Punk women participants exposure to trauma events. As a child, the 83%, if you see, they ever witnessed their parents hitting, slapping, beating, and physically hurting each other. So, which means their family background or how their parents behaved in front of them have also really made them what they are today, made them indulge in drug use before the age of 17. So we are looking at childhood that would be below 17 years of age. So and I think look at the wings and under the wings module, how well we have been able to identify the violence as per the data. But then apart from that, how has wings been really helpful in making the women drug users access HIV/AIDS treatment, care, and support is something which is, which is an added value. This is how we see wings, not just responding or identifying the gender-based violence or intimate partner violence among them, but also looking at, what benefits has it brought more. Because these 50 women that Sahara has identified were never ever, referred or got access to HIV treatment, care, and support. As they were really living in a very, very vulnerable situation, they had never been to any care centers or health providers or health posts to access treatment. So WINGS was something which helped these women to also get access to the treatments. So just to share with you all a brief data, out of given target of 50, as I said, 47 were registered under WINGS and went through all the sessions as per the WINGS model. Total of 12 FGDs, focus group discussions, were done in 6 months. And these focus group discussions were majorly to bring all these women to a group and make them open up with their, with their feelings, with what they have gone through, so that they feel relieved, and they also started to be more confident on coming out with their issues. 2 women were placed in drug rehabilitation center because they really wanted to get out of their drug habit. Like 19 women, see, HIV testing could never be forced, as it's voluntary counseling and testing, right? And it's up to the woman if she wants to really go for HIV testing. Therefore, out of 50 women, 19 were referred for HIV testing, and out of 19, 5 who were already diagnosed HIV positive were referred for ART, the antiretroviral therapy, to the ART centers. And this was made easier because Sahara Care Home, the NGO Sahara, already has a care and support center for the PLHIVs, so it was easy for them to link with the services, right? And because, as I said, that all these women are street-based, they don't have any government identities which would help them access the benefits that the government are giving to the women. They don't have identity cards, nationality cards, citizenship cards, or credit card. So we really help them. And for 5 women, we also came up with the bank accounts. We developed that for them. Admitted into the hostels. These children are of the women because they really needed a daycare center where they could send their children and then they can go for work. Through this FGD, if you see, informal support groups were formed, and when these informal support groups came into existence, these women were able to, help each other in raising the voice and taking help from the law enforcement. So one woman who was really, harassed by her own family, daughter and son, to earn for them, and the violence was too bad with her, and she was really suppressed. But when this informal group came into existence, she was able to go to the police because her friends, other women using drugs was helping her, okay? And 3 women gathered the courage and called the police in times of violence. They had never done this before. So it was WINGS who brought this courage to them, WINGS has really made them fly, I would say, in that sense. Non-compliant on ART therapy have stabilized and adhered. So 2 women who were HIV positive and already under ART, they were not adhering to the ARV. But then after WINGS intervention through the team, our peer recruiters, they really helped her to get back to the ART treatment. However, we were given a very short period of 6 months, and you don't want to talk about challenges? Why not challenges? Okay. So I just want to switch off my slide on challenges and go to the lesson learned. So as we move with this project, which has ended unfortunately on 31st of May, we are now looking at continuing with the phase 2 of the WINGS, where we would be through the experience that we have WINGS 1, phase 1, now we want to move ahead and have more activities and more interventions at all levels and in all areas like advocacy, capacity building, more referrals to treatment on HIV, TB, co-infection, Hep C. All these things would come up as, in phase 2 of WINGS. including the wings model itself, and it's basically like we also want to see how well we can develop partnership and linkages with other appropriate referrals that we can give. And it is also very important to define GVB and IVB to the participants in the first place, so that they understand that it is not that all they have in life. They can still move, because women who, like drug users that we intervened, thought that it is end of their life. So to make them understand that you all are going through a violence which can be suppressed, you can come out of this situation and move ahead, that is also something that we really want to do for them, as that is something which is coming up as a need. We need to be extremely respectful in the presence of other family members during the sessions. When we are taking the sessions, it has happened that, all of a sudden, her husband comes, or her family, brother, sister, they come and then they try to intervene. So in front of them, again, the woman cannot open up. So we have to really look at places which is very, very friendly and flexible for them to open up. That openness, opening up with their issues, has come up as a main problem with them, because of the stigma and discrimination, yes, that they were facing every day. So this is more or less what we have done so far in a very short period of time, trying to add value to wings and make services more accessible for the women who use drugs in India. So that is it all that I can present to you all. Thank you and namaste.